And good morning. We are streaming surgery live Tuesday, March 19th, 2024. Who put 2023? Our first patient has 4 herniated discs. One of them is at C7-T1. We can't reach it, but we're going to go for the top 3, and the top one, C4-5, is the worst. It's pushing on his spinal cord, making him paralyzed. Now he has a thick neck and big shoulders. He's a big guy. We're going to do our best. We've got him relaxed, 0 twitches, and he is asleep with the tube. I can feel his spine quite nicely. And we want to start at C5-6 ideally and work our way down to 6-7 and up to 4-5. Let's see what we've got. Shot. All right, so we're going to need a shoulder pull, Luis. Come on. Okay. Neck, hold the neck in line. Shot. All right, 2, 3, 4, 5, 6 is there. We're going to have to do a little bit better, guys. Shot. All right, that's pretty good. 2, 3, 4, 5, 6. I need to be a little bit lower. And I'm going to need an AP, which will be a very quick AP, Jordan. All right. And a little shoulder pull shot. Perfect. AP. Let's go see where we are quickly. Shot. All right, so not bad. All right, I need you to pull both shoulders from me, Luis, as I advance. Get the head in line. Don't let it move. Shot. That's it right there?
Yes, sir.
All right. Shot. Shot. All right, I need an AP now. Stay where you are, nobody move. 2, 3, 4, 5, 6. Shot. Perfect. Shot. All right. I'm in the disc. So it looks like if we can improve that a little bit. Shot. Get your hands down a little lower, Luis. I need you to move the fluoro south, Jordan. There we go. All right. 2, 3, 4, 5, 6. All right, let's get an AP. Good job. We're going to do a discogram. Hold on. Coker. All right, right now we're gaining access to the discs. The first one we're going to gain access to is 5-6 shot. We don't need to pull. Beautiful. Now I'm going to do a discogram. Shot. All right. Let's do a little more. Shot. Lateral. You can see the dye is leaking out through the back, right along the nerve roots. Let's get a stylet. No, stylet. Jordan, I need you to clean up that image a little bit. Hold on. I need you to zoom in. I need you to clean up that image. Shot. All right, that looks better. That's better. 2, 3, 4, 5, 6. Everyone agrees? All right, let's put our guide wire local. So what we're doing, for those of you who have not seen this surgery, we're doing endoscopic spine surgery. And this is true endoscopic. Minimally invasive. It's done through the front of the neck, like an ACDF, except we're not making a big incision like you would with an ACDF. We're going to make a 4 millimeter incision. 4 millimeters is very, very small. All right. Now, let's see where the guide wire is. Shot. All right. Shot. That's better. Shot. All right. So at this point, Our guide wire is in. Shot. And we need to get to the back of the disc, which I'm going to work on next. If you have questions, you can ask us. We'll do our best to answer them. Now, he does have a thick neck, but the biggest problem is not the thickness of his neck. It's his shoulders are quite broad, and they're blocking our x-ray machine. And we do have the very best x-ray machine you can buy. Unfortunately, it can't work magic. And going through some of our patients' shoulders is asking just too much. But let's see what we can do here. 5, 6 we've got, 4, 5 we've got. Remember, the worst level is number 4, 5. Good job, Luis. Okay, I got it. We're gonna now move, I don't need that. Just put it down there. Shot. Good. So you can see the dilator is moving down towards the spine along the guide wire. Shot. Now I'm in the front of the spine. Let's go ahead and do an AP. Shot. Perfect. We're right in the middle. Just a little bit to the left by a few millimeters, but that's really good. Really good. I'm happy with that. Now I'm going to advance the dilator down into the disc over the guide wire, and I'm going to remove the guide wire. I'm actually passing through the front of the disc, and the dilator is not cutting anything. It's spreading the fibers. Hold on. Shot. All right. I think we're ready. So the tip of the dilator is it's pointed, and what it does is, shot. I think you're off on orbit a little bit. Maybe is the head straight up and down? He has a little bit of scoliosis probably. All right. Yeah, we're a little off on orbit. You're off on 1 degree. You can see the back of the facet. There we go. That's almost perfect. I think we're still off by ½ degree maybe, backwards, or keep going. That's better. Is it, or is it worse? Kind of hard. Try the other way. It looks pretty good to me. Shot? No, that's worse. So you had to keep going then. That's good. That's really good right there. I'm happy with that. I'm happy with that. It's very important, your information shot from your x-ray machine, which is what you're using to navigate. You have to make sure it's accurate. All right. We're at the back of the disc with the dilator. And as I was saying, the dilator itself does not cut. It spreads. So the only damage this surgery does is the incision in the skin. Whereas if you're doing an ACDF, you're doing damage the whole surgery. You're doing damage to the skin. You're doing damage to the muscles. You're doing damage to the tendons and ligaments. You're cutting them all. And there's scar tissue and bleeding as a result. And then you're cutting the disc and cutting it out, actually. All right, a little inline traction. Okay. Come on, Luis, put this here. Put that here. I need that. What are you doing? No, I need to advance the tube. All right. Shot. We're going to go nice and slow. Perfect job there, Jordan. Amazing. Oh, look at that. So the dilator came back. Shot. The reason it did is this disc is under pressure. The reason the disc is under pressure, it shouldn't be, by the way. A normal disc is under 0 pressure, but this one's under pressure because, shot, it's full of inflammation. Why is it full of inflammation? Well, the patient has an annular tear in the back of his disc, and that annular tear is where the inflammation is happening. And that's right on the periphery of the disc, in the posterior part of the disc. Shot. All right, here we go. Just a little more. All right, that's about as good as I'm going to get it. So far, so good. Henry, show our audience how do herniated discs cause neck pain and arm pain through inflammation. Okay, now you understand. Come on, guys, laser on. Now you understand how the tear in the back of the disc, Luis, can we get things right, please? Is the actual cause of pain through inflammation. The laser is how we fix it. The laser is very effective at removing the inflammatory tissue, the herniation, and cleaning up the edges of the annulus, which are torn. The edges of the annulus will not heal on their own without being debrided. You need to do a debridement. A debridement is a surgical term meaning clean out, and if you don't clean it out, it's not going to heal. So the only way to get a disc to heal properly is through a debridement. And there's a lot of products out there on the market that claim to heal discs. They don't. Like the barricade device, it doesn't work. Injecting gels and things in the disc doesn't work. What works is this surgery right here. This is the only thing that actually works. And the reason it works is we're debriding the tear. We're cleaning out the tear. That's the first step to get the disc to heal. You must debride the tear, and that's done with a laser. There's no other tool that does this properly. I've tried them all. You can use metal tools, you can use plastic tools, you can use ultrasonic tools, you can use pretty much anything. And we've done it all. Radio frequency, it just doesn't work. The only thing that really works is this laser. And the laser is, for reference, what you're seeing, the little glass fiber is a fiber optic fiber, and it's 1/2 millimeter, 0.5 millimeters. So a millimeter is the smallest space you can see between your fingers. The exposure is too high, guys. Bring the exposure down 2 clicks. That's good. All right, so this is the annular tear and the herniation. We're actually removing the herniation as we speak with the laser. You see how it's disappearing, the white tissue, the blue tissue? It's going away. And what you're seeing is the back of the disc. This is scar tissue and herniation right here. The gold stuff is calcium or calcification. Any questions?
Yes, we got a couple of questions. This first one comes from Nicholas on Facebook.
Hi, Nick.
Asking, how are you able to know the carotid artery, phrenic nerve, vagus nerve won't be injected when going in with the tool? I've been reading a very good literature on DLDR.
Uh-huh. Yeah, well, you know because you push them over with your finger. So it takes skill. That's why we train as neurosurgeons, to avoid injuring things like that. But you're right, they're all right near the area that we're working. Next question.
This next one is just a comment. I thought it was a question. This comes from King on YouTube,
Hi, King on YouTube, welcome.
saying, I got a new MRI upright. I believe you would want to see this one. I am debilitating in pain. I am in debilitating pain, neck and left shoulder / arm.
Well, I'm happy to look at your MRI. You get a free MRI review. We offer that to everybody out there who wants to take advantage of it. And all you have to do is go to our website, fill out our form, and send us your MRI. Right now I'm using this laser to remove, basically this is all inflammatory tissue at the back of the disc. The gold stuff you should not be seeing, that is calcification. It's abnormal. And this is right here, what I'm getting right now is scar tissue and herniated disc. So it's basically scarred up herniation. Herniations are basically fragments of the nucleus pulposus that's found normally in the center of a disc, and those fragments are over time, due to the effect of inflammation, scarred. Now this is the back of the vertebral body right there, the back of the end plate, and this is a broad-based herniation. It runs from one side of the disc to the other. It's quite large. But so far, everything's going well for our patient. He is completely asleep and doing quite well. More herniation here. And we're just going to keep removing the herniation. To give you an idea of scale, the fiber is 1/2 millimeter. The inside of the tube is about 2.8 millimeters, almost 3 millimeters. The tube is that metal tube you're seeing, that circle that I'm working through. You're watching the most advanced spine surgery in the world for herniated discs in the neck. It's called the Deuk laser disc repair. It is a type of endoscopic spine surgery, true endoscopic surgery. This was pioneered originally by South Koreans, and I learned from them, from the originators of the technique, Dr. Sang-Ho Lee. He's a neurosurgeon in South Korea, and he's the founder of a system of hospitals called Woodidal Hospital, Woodidal Spine Hospital. I don't know how many they have now, about 8 of them throughout Korea. They put them at the airport so people can fly in, have surgery, and then fly home the next day. It's a pretty cool concept. Anyway, Dr. Sang-Ho Lee was the originator of the endoscopic surgery in the neck, and that's who I learned this technique from. He and Dr. Gun Choi, his right-hand neurosurgeon. This is all scar tissue sitting right on top of the nerves and spinal cord. It's pretty bad. Scarred up PLL, posterior longitudinal ligament, very scarred right through here. This is right up against the posterior ligament, called the posterior longitudinal ligament. This is a big herniation, been here for a while. See all this right here? That's all herniation. I'm using my laser. Oh, look at that piece that wants to come out. You guys see that? It's about to come out right here, right where I'm working.
Yes, we do.
That's sitting on the nerve root, right there. It just came out. You guys see that?
Yes, we
So
did.
that's what this surgery does. It basically uses the laser energy to fragment or break up the herniation into smaller pieces to remove it and to free it off of the scar tissue scarred to the back of the disc. Now, this patient's alternative surgery would have been an ACDF fusion He didn't want a fusion. I don't blame him. I wouldn't want a fusion. I've done 1,000 fusions in my career, 1,000 cervical fusions, and this is a much better surgery for patients. It's safer. It's we're not removing the entire disc like you do with an ACDF. Can we not make that noise, please? With an ACDF, you're taking the entire disc out. And then once you get the disc out, you're like, well, what do I do now? And you have two choices, well, three choices. Put nothing there, and the patient will be in pain the rest of their life, or put a spacer. Now, the spacer you put there is either going to be a cage for fusion, or it's going to be an artificial disc. And either one is a bad option. They both have lots of problems. Turns out artificial discs have the same rate of adjacent segment disease as fusion does. And for years they were promoting artificial disc as, you know, technology that doesn't have adjacent segment disease, but it does. There's another piece of herniation. Look at the size of that one. That just came off of the nerve root. Literally was sitting on top of his nerve in the neuroforamen. So I can't even get it out. It's too big, so I'm breaking it into smaller pieces with this laser. Hopefully, when I get it small enough, it's going to come out. Right now, it's pretty dense. It's got a lot of calcium. You see that? It's that gold color. So it weighs it down. It makes it heavier when you have all that calcium. There we go. But if you break it down into smaller pieces, what happens is the fluid of my irrigation will float those smaller pieces out. All right, almost done on the right side. Look at how much, so there's the nerve root down there. You guys see it, the white thing down at the bottom? And this is all scar tissue from the herniation, sitting on top of it. Now the reason why other doctors don't do this surgery, it's very technically challenging. Even the South Koreans don't do that much of it anymore because they've had some problems with their patients, some outcomes that are bad. They recommend fusions more now than endoscopic. So Deuk Spine is truly the world leader on this technology. We do more of these surgeries than anybody else, and we do them with better results than anyone else. We've published our results in the medical literature. You can read about our procedure. It's called the Deuk laser disc repair. It's published in the National Library of Medicine in Surgical Neurology International. It's a very prestigious journal for neurosurgical procedures and neurosurgery. Any questions?
Yes, we got this next question from Lanu on YouTube.
Hello, Lanu, on YouTube. Welcome.
Asking, will there be anyone to take over if you retire someday? Future patients would need your service.
You're right, Lanu. Thank you. I appreciate that. It means a lot. I'm hoping my son, Arias Deuk, who's also, by the way, an author on the publications, he was there with me in the beginning when I was publishing and doing the studies, and he helped out. So he's actually an author, and he's very interested in carrying on the Deuk Spine Institute tradition. So if we're lucky, he will go into medicine and he'll become a surgeon. I'm hoping, you know. But you know how it is with kids, you never know what they're going to do. But right now he's at Princeton University and he just got his grades back and he's got straight A's, you know, taking chemistry, biology, writing, and Korean. He actually is taking Korean language. He's got an A in Korean. It's amazing. I was terrible at languages. Thank you. But yes, Arias and then my daughter, Ariana, I'm hoping she will take over as well and do these surgeries. So yes, we plan to train more surgeons and we plan to carry on after I die. We will have somebody succeed us because this technology is too important. And the truth is, I don't trust just anybody to do it. This is not a procedure that just any doctor can do. It requires a tremendous amount of skill. And there's a lot that can go wrong. Unfortunately, there is. And so it's not something that you can just, willy-nilly pick up. Of all the surgeries I do, this is the most challenging surgery, the cervical and the thoracic laser procedure that I'm doing now. It's the hardest. The patient has to be asleep completely. They're under general anesthesia. Our anesthesiologist, Dr. Berndes, is sitting next to me. And, somebody asked a question earlier, how do you get past the carotid artery, the jugular vein, the vagus nerve? It takes a lot of skill, a lot of practice, a lot of experience. And it takes a lot of being careful, knowing where they are, how to avoid them. You know what I mean? And all that's important to have a good outcome. And we've had great outcomes. This surgery has better outcomes than any other disc surgery in the world. There's nothing that has better outcomes. That's a bone spur right there. I get a lot of questions about bone spurs. I just zapped that thing away. You guys see that? That was no problem. This treatment is no problem to get rid of bone spurs. Speaking of the treatment, let's show the audience how it's done, Henry.
Copy that.
All right, welcome back. So you understand now how the laser is used with the endoscope together. You can't just use one without the other. You need both, the laser and the endoscope. And the name of the procedure is the Deuk laser disc repair. We're just about finished with this disc. Just a few more minutes, and I know we have some questions, but you can actually see how I'm debriding the tear, cleaning the tear so that the body can heal it. By the way, the reason all this scar tissue is here that we're cleaning right now is his body has been trying to heal the tear itself, but it cannot. You good? He's trying, but the body cannot heal these tears because the herniation is stuck in the tear. But look at that, the herniation is gone. That's the nerve root right there. Literally, that is the nerve that goes down his arm. And it looks fantastic. And the herniation is gone. So we're done with that one. We'll take some questions.
This next question comes from Royal ViewTube on YouTube,
Sure.
asking,
Welcome.
Doc, are you familiar with the term dermatomal pain?
Yes, dermatomal pain, sure. Yes, I am.
All right. And this next question comes
Well, dermatomal
Yeah.
pain just means pain that goes down your arm or leg or, trunk in what's called a dermatomal pattern. And the dermatomal patterns are all about, where the nerves go. So the nerves go down, they're like a little river. They go down and they have little branches of water, tributaries, let's say. And the nerve is the same way. It goes out and it basically innervates, it brings sensation from an area. like a strip of skin. It's a long strip of skin. And so that's a dermatome, okay? And each nerve has its dermatome. You know, the textbooks tell you where the dermatomes are, but the truth is, everybody's different. All right, look at that, beautiful. Okay, now we're gonna have to try to work some magic here and get down to C6-7. Let's see what we can do. Jordan, I need you to do your best. If we can't get there safely, we can't. But let's see. Shot? Is that it?
Yes, sir.
No, you got to do better than that. You had a nice picture earlier. So you got way too much exposure of the air, and that's hurting you.
Okay.
Shot? I think the table needs to come up.
Table coming up. You got that, Jordan?
That's not bad.
Okay, we're gonna come up.
Or your collimator needs to come down. That's it. That's enough. Shot? How is he on his shoulders? Yeah. I would go back, I don't know, Jordan, north a little bit. Shot. Come on, Jordan. Get the collimator down. Get rid of all that air. Other way. There we go. Shot. That's better. Give me a little less in the back of the spine. Come on, Jordan. These are things you should just be doing automatically. They're not neurosurgical things. All right, what can we do to make that better? Try that. So the collimator is a metal plate that basically focuses the radiation, the X-ray, through a smaller diameter or a smaller port so that it's more concentrated but gets rid of. Now that I might be able to work with. I might. Right there. Okay? So first of all, I'm going to take this tube out. Shot. All right. It's going to require some miracle. Shot. Yeah, I don't want to go in any further. Shot. All right, good. Tube is coming out. Shot. Got to keep an eye on my dilator. That's what I'm talking about. This can be a very difficult surgery. Shot. If you're not really paying attention to where everything is. Shot. All right, so I'm out of the disc with the tube, but I got to get the tube up. Shot. And that's what I'm working on right now. Hold on. Shot. I think we're out. Shot. Yeah. Shot. He's not making it easy. That is 100% for sure. All right. Why am I struggling to get the tube out? Shot. Let's take the cap off. The fluid adapter. Shot. All right, now I'm going to try to get this tube out. Shot. Man. His skin is just pinching it so tight. Shot. Shot. All right, so I got my dilator in place. Shot. I'm going to start backing it out. And we're going to make an attempt to get down to C6-7, but it's almost impossible to see. So, Jordan, are you ready? Maybe get rid of some of that white up top. Yeah, that's fine. Now bring your full fluoro south. Shot. That's it. That's probably the best we can do right there. Shot. I could see the front of the disc. I could see the disc space. Let's see if we can make this happen. It's very difficult, very challenging. This on a scale of 1 to 10 is a 10 for me. Whew. All right, here we go. Shot. I need to pop out. Shot. I feel like I'm right on the edge. And I am. Here we come. Let's come out. Feel like I'm out. I am. Let's get an AP. I'm sitting on the front of the spine, just on the top part of C6. Shot. He's still relaxed, right? All right, now I'm going to try to make my way down to 6-7 safely. Shot. Let's go. Shot. AP, almost there. Huh? I know. He's got a very strong, thick neck. That's the problem. All right, almost there. Let's go back to a lateral. The AP looks really good. All right, I just got to get over that little hump right there. Let's see if we can make this happen. Okay, shot. Feel like I got it. Give me an AP. I definitely moved. Nobody move. Everyone stay. Shot quickly. All right, at dead center. We'll go back to a lateral. This looks good. Give me the mallet. I know this is complicated for you guys to follow. Believe me, it's hard for me too. This is not an easy case. This is as hard as it gets. Shot. This 6-7 is almost impossible because the disc is angled downwards. Shot. Man. No, you're fine, Jordan. I've just got to see if I can hold this for a second. See if I can get the angle right. Shot. If I can't get the angle right, I can't do it. I'm really fighting his neck. Shot. No, don't pull on his head. Flex him for me.
Okay.
Yeah. Shot. On a scale of 1 to 10, this is a 15. Shot. All right. Well, we're halfway there. Let's pipe clean and do a discogram. Let's see what we can do here. So as a surgeon operating on a real human being, you have to weigh risk, shot, with everything you're doing, shot. And you got to ask yourself, is the reward for the patient greater than the risk? And that's the question we always ask as surgeons, shot. I can't get any dye out. All right, we're almost to the back of the disc. Take this for a second. I gotta. So, the problem is the disc is pointing. The front of the disc is pointing down towards his feet. So I'm like struggling to get the angle right at this particular disc. Shot. 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 I'm almost there. Guess we can go a little more. All right. Let's bring that tube down. I just don't know if we're going to get this. I'm really having some doubts. The C4-5 won't be as difficult. Let's try that. Wait. Help me by pushing this right here, just gently. No, not there, down below. Yeah, there we go. Shot. All right, let's just see what we can do. Shot. Keep an eye on that tip. Jordan, shot. Oh, that's really good, Jordan. How'd you get it so clean? At least the tip is not moving back. You can see we're entering the disc. Almost there. Keep doing what you're doing, everybody. A little inline traction if you could.
Here we go.
Hold this, Luis. Hold this.
Some more inline, less extension.
Almost there. Let's put the dilator in a little further. Shot. Hold that. Shot. All right, little inline.
Yep.
That's as good as I'm going to get it right there. We're done. Take that. All right. If we can get this out, we're good. AZ doing all right?
Yeah, I'm just waiting on the full size for that. Because we're working on this.
Luis, I need you to get this out from me without taking my tube out. Yeah, I'm good. Huh?
Do you want to put that after to hold it?
I can't hear
That
you.
after. Do you want to put that after and hold it?
Sure. The fluid adapter. Yeah. All right, go ahead.
Maybe the vice grip, just in case.
There's no way we're gonna need the vice grip. You think?
There you go. We got it. Thank you.
All right. That's one of the hardest I've ever done. Look at that. I mean, he's made it so difficult because of his anatomy. Let's see what we can do. I don't know if it's going to be good enough. We'll try. But it's the best we can do here. Unfortunately, some patients' anatomy is just not good for surgery, any surgery. And it doesn't matter if you do an ACDF or you do the DLDR endoscopic, it's the same. Because surgeons have to struggle to get that angle where they're looking up the disc. So you have to get low enough, and the problem is the collarbone gets in the way. And that's what's happening. His collarbone is huge, his neck is huge. He's got a lot of muscles and soft tissues. Flip it. But we're here, and it's not ideal, and his chest is huge, by the way, and it's pushing my scope. I may have to change the irrigation side to the other side. Let's do that. Grab that, switch it. So we're putting the irrigation on the other side. That gives us a little bit, like a few more millimeters of room, okay? Which could make the difference between a successful procedure and a non-successful. Let's see. Hold on. Any questions?
Yes, we
A
got
lot more bone spurs here, a lot more chronic inflammation. Go ahead.
This next question comes from Jamie on Facebook. Jamie asking, are the medical journals available for the public?
Yes. Yes, Jamie. So Surgical Neurology International, where we published our research, our study, Deuk laser disc repair. If you Google Deuk laser disc repair, it'll give you something called PubMed, P-U-B-M-E-D. That will be one of your options at the top. You can click on that. That is the medical journal article we published. And it's open source. That's why we published it the way we did, was that way the public could read the articles. Otherwise, you'd have to pay money. A lot of journals make you pay money for their articles. They'll make you pay $120, $150. We didn't want people to have to pay. We wanted, I thought you were going to open it. We want people to have it for free. Because the more people that can have it for free, the more likely people are going to read it. So, after all, that's what it's there for, right? It's there to be read. But some of these journals are greedy. All they want is money. And I understand it costs money to, to do the research and editor and all that, but have the authors pay, They do anyway. They charge the authors. Ugh. Yeah. Is he still pretty relaxed? This disc is a lot worse than the last one. Huh? Where is he? Yeah, I just give him a titch more. Any other questions?
Yes, this next question comes from Sydney on Facebook,
Hi, Sydney.
asking, what kind of laser are you using?
We use a medical laser called a holmium YAG laser. Holmium YAG. Holmium YAG. It's the best. It's the best laser you can use. There's nothing better for this application. Man. A lot of bone spur, a lot of scar tissue. This disc is worse. Worse. In terms of collapse, it's not symptom worse, it's just collapse worse. All right. And the problem is, again, his anatomy. It's not that my tools aren't any good. We're doing everything right. But his neck is so thick and muscular, but more importantly, his collarbone right now is what's restricting me. His collarbone. And the disc itself. This disc is so damaged and so much scar tissue from years and years and years that it's the bones are basically glued together or cemented together from scar tissue, but we're still getting it done. I mean, this is all herniation right here. This crack right here is the herniation. And these are bone spurs on the right side of my laser. So just behind my laser is scar tissue from the herniation and the herniation itself right there that I'm zapping. And just to the right that I'm now there is bone spur. Okay? So not an easy case. All right, any more questions?
Yes, we got a couple more questions. This next one comes from Billy on Facebook,
Hi, Billy.
asking, is there anything can be done if the doctor tells you that it's nerve damage?
Yeah, you can unpinch the nerve with this surgery, and the nerve has a good chance of healing as long as you do it well. A lot of surgeons don't know how to do the surgery properly. So you got to find the right surgeon. That's really key. I'd say if you just go out there and pick surgeons, 9 out of 10 won't be the right surgeon. 1 out of 10 will be really good and know what they're doing and be able to help you. But you got to go to the right doctor. There's unfortunately, a lot of spine surgeons that are not so good out there. I know about it. I've seen the results of their work. All right, just about done with this disc. And the reason is I can't get any more. I'm limited by his anatomy. His chest is preventing me from getting further. But the good news is this, of the 3 discs we're fixing, this is the least important to fix. The number 4-5 and the 5-6 are the most important. All right, we're going to take one last pass, and then we're going to move on to number 4-5. Everybody ready for the last one? Any other questions?
Yes. These next 2 questions come from Forgive me, I can't pronounce the name. We're just going to go with Abby on YouTube. And
Hi, Abby.
first question they ask, will the hole on the disc close after the surgery?
Yes, the hole in the disc will close after the surgery.
And
After this surgery.
And then this next question asking, can this procedure cure stenosis?
Yes, this procedure can cure stenosis. By removing the herniation, that's what's causing the stenosis. All right, I can't get any more. I'm not terribly satisfied with that, but it's the best I can do. And the good news is this disc of the 3 that we're fixing is the least problematic. So hopefully what we've done is good enough. We'll see how he does.
We have a couple more questions.
Sure, I'll take them.
This next one from Kane's Life 2 on YouTube. Asking,
Kane's Life 2.
Kane's Life 2 asking, I've had 2 spinal fusions in 5 years. I'm sending my MRI report to you soon. But
We can help you. Yeah, we can help you.
My question is, recently I developed this terrible aching pain in both arms when I wake up. Can this be related to surgery? Thank you.
So why do you have aching pain in your arms? You need a diagnosis. Can it be related to surgery? If it happened right after your surgery and you didn't have it before, then I'd say it's related to surgery. But a lot of people have aching pain in their arms. So it could be a pinched nerve, it could be stenosis. The point is, if you're waking up with it, it's something that's dynamic and it can probably be fixed. So that's the good news. We can probably fix it. All right, shot at Deuk Spine, but not many surgeons can. So choose your surgeon wisely. That's all I can say. It's very important to choose the right surgeon. Shot. Right now I'm trying to get the tube out. I'm sliding it up and over the dilator. Shot. All right. So, 2 down, 1 more to go. Shot. I need to get this tube out, this dilator out, get it on the front of the spine. Jordan, I'm going to need your help. I need better pictures than that. Should be out. I'm out now. Shot. All right, Jordan, come on, let's get north. Let's get a better picture than that. Need your help here. That's pretty good. I can live with that. Let's get an AP, see where we are. Now the lateral views are worse because the shoulders are big and this guy's got a thick muscular neck and big shoulders, so it's blocking the x-rays. But the AP views are usually better. See how clean that AP view is? Nice, pristine. Okay, we're pretty much in the center. I'm going to just march this right up to the 4-5. I need a little bit more help. Shot. I think I'm in the 5-6 right now. Yeah, I can feel it, the defect coming up and out. And we're up and out now. Shot. Yeah. 2, 3, 4, 5. Making my way north. Shot. All right, 2, 3. You're off on orbit, man, big time. All right, we need to move our way north. There we go. Shot. All right, give me an AP. I feel like I'm off on the side a little bit. We want to get back in the center. There's a center part of your spine in the front that's real safe. Actually, that's pretty good. It's right, it's called the anterior longitudinal ligament, ALL, and it's just a ligament. There is a little bit of veins along the way, but it's pretty safe. 2, 3, 4, 5. All right, we're just centimeter away from achieving our goal here. And right there, shot. I went up a little mountain, and I'm right over the disc. Shot. AP. So I'm looking good on the lateral for 4-5, which is our last disc, and I want to check my AP. Never, never, never do this surgery without checking AP and lateral. You want to check both. You need three-dimensional information. Never go on one-dimensional, two-dimensional. You need three. Shot? Shot? Nobody move. AP? Nobody move anything. You guys are moving around and it moved me. Shot? Give me a better picture than that's rotated. You're rotated towards me. Rotate the other way. Rotate the top. There we go. Shot. Nope, other way, sorry. I guess his head must be turned a little bit. Uh-huh. Is that, let's try to get a little more midline. I could see the spinous process above. It still looks a little off. Shot. Rotate, Jordan. To get the heads looking straight up, please. Shot. All right, I'm a little bit off to his right. Take that. Shot. By the way, you got to have really good feel with your hands. Lateral. To do this kind of surgery. If you don't, forget about it, because it takes, like, literally I have to feel the tip of this thing as part of my hand. It has to be like an extension of my hand. There we go. All right, much better. Shot. Give me a pipe cleaner and let's do a discogram. Find the tear at the back where the big herniation is. This is the big one, folks. This is the one that's the worst. Shot. On the MRI shot, you can see on the MRI shot that shot. There we go. This is the worst place where the spinal cord is getting crushed. The nerves are getting crushed the worst. He's got so much scar tissue, shot, that I can barely get the dye out. His body makes a lot of scar tissue. I can't even get the dye out. That's impressive. I'm putting a lot of pressure. The dye is barely coming out here, Luis. I wonder if there's something wrong with the injector. He definitely has a lot of scar tissue. Shot? Oh. Oh well, couldn't really get it. The disc has too much scar tissue from chronic inflammation. You're off on orbit a little bit there, Jordan. Just a little bit. About half a degree. Go ahead. Folks, I'm going to show you the incision in just a second here. You're going to be amazed. The whole surgery, 3 discs, is being done with a 4mm incision. 1 incision, 4mm. It's actually about 5mm. That said, it's tiny. Shot. And he's going to have really no scar tissue from the surgery, no damage to the muscles, tendons, ligaments, nothing. Not even the swallowing tube. Come on, Jordan. Every time I look up, it's a shot. See? That's why you have to take the shot, Jordan. You see the dilator shoot back, guys? Pressure. Tremendous pressure in this disc from chronic inflammation. Shot. All right, let's try this again. If you're not paying attention, shot. See, it moved back already. I didn't even take a hit, and it's already moved back. Take a hit. Sounds terrible. Shot. My God, the pressure is amazing. I'm hitting this thing down and it's bouncing back like rubber. Way too much inflammation in this disc. Shot. That's where all this pain's coming from. Shit. Keeps popping back. You guys see that? I'm not even doing anything. It's just popping back. Shot. All right. I got to try to keep it from sliding back. Shot. Alright, let's try something here. Come on now. So what I'm doing is, for the future endoscopic surgeons, I'm pinching the dilator with my impactor. Trapping it with a sidewall so it can't go back. Alright, look at this incision. Henry, show them this thing. Yeah, the whole surgery is being done through this tiny, tiny little cut. You guys see it? Move that out of there, Jordan.
Yes, we can.
Right here. Now, let me have a marker. Let's say this guy had an ACDF instead, or an artificial disc. The incision would be like this. Okay? Now, you might say, well, I don't care if I have a small incision or a big incision, doesn't matter. What you guys don't understand, big incision means lots of damage internally. The surgeon's chopping you up inside. And you guys don't get to see that. All you see is an incision, and you're like, oh, no big deal. But what you don't understand is they've butchered everything inside, like a slaughterhouse. All right, cutting your meat. And that's why people after these ACDFs and artificial discs, they can't swallow, because there's so much trauma to all their soft tissues. You know, the complication rate for ACDF, anterior cervical discectomy and fusion, is 50%. The complication rate for this surgery is 0. We've never had a complication. So we've done literally over 1,000 of these, and we've had 0 complications. So it's very safe. If you read the paper on PubMed, it's safe and effective. The safe part is key. Who wants to go have surgery and have a complication? Nobody. Nobody. All right. Any questions?
Yes, we have a couple questions. This next one comes from Zach on Facebook,
Hello, Zach.
asking, are you using a Moses laser or a different holmium?
A Moses. No, we're not using the Moses. Sorry, Zach. I hope you don't work for them. No, the Moses is overpriced, unnecessary. We won't, the problem is Moses laser is just way overpriced. Same laser, they've just made some changes to it to make it worse. And they've jacked the price up. So we won't use the Moses. Unless they give it to us for free and they pay for all the parts and repairs for free. So what Zach is referring to, folks, is the manufacturer of this particular laser is Luminous. Luminous was bought by Boston Scientific. And Boston then, first thing they did was jack up the price, double the price of the laser. And then they made all the parts more expensive, and they made it so that technicians, independent technicians, can't work on it. So the Moses is a laser that independent technicians really can't work on. So you have to be a Boston Scientific technician. The problem with that is, instead of, getting 40 bucks an hour, they want 125 an hour. So they've just taken this beautiful product and they've bastardized it, and they want their $1 billion that they paid for Luminous back as soon as possible. It's all owned by venture capital. If you go look up who owns Boston Scientific, it's all VC, right? And VC wants big returns on their investment. So Boston uses VC capital to basically buy companies that are along the supply chain and then jack the prices up for end users like us. And then we have to pass on those charges to our patients. Everyone wonders, why are the costs going up? Well, we've kept our costs basically stable because Deuk Spine Institute, we're frugal. We look for every way we can that's going to actually save some money that doesn't compromise quality of care for the patient. So we're always trying to keep costs down, quality at the highest level. So we're still using the predecessor of the Moses, which is the, what the hell is the name of this thing? Versapulse. Look at all this herniation. I would not use the Moses. There's another reason I won't use the Moses. It has nothing to do with the economics. It has to do with functionality. The Moses does not create as much of a pressure wave. And the pressure wave is very important for what I do. So everybody thinks it's just a laser, but the laser energy does two things. It it gets absorbed by these tissues and it breaks them up into smaller pieces. We got 5 minutes left. The other thing it does is the laser energy creates a pulse, a shock wave that really shakes up all this debris, you know, and makes it come out. Otherwise, it won't come out. See how it jiggles and comes out? If I didn't have that pulse, it wouldn't jiggle and come out. All right, flip it. Any more questions? These are good questions.
Yes. This next question comes from Kane's Life 2, once more on YouTube.
Welcome.
Following up on their 2 surgeries in 5 years, they said, yes, my first fusion surgery was horrible at L5 to S1. My second surgeon attempted to fix his mess-ups. I still have burning/weakness in my legs. Pain doctor wants me to do a simulator, but I really don't want that. How far out are you all on surgeries, Dr. Deuk? Do you know?
So if you're wanting me to fix you, hit Deuk Spine, we can fix you within a week. It just depends on how motivated you are to get fixed. So if you're really, really motivated to get fixed, then fly here. If you're not in Florida, fly here with your MRI in your hand, see me in clinic, and I will diagnose you right then and there what's wrong, and I will fix you. All right, that's what we do. And we can do it, you know, if you're motivated, we can get it done in a week. Otherwise, you go through the process of the free MRI review, which is done virtually, and that could take a few weeks, 2 weeks, up to 2 weeks to get done. And then you've got, you know, scheduling, which could take another week or 2 or 3. So I would say typical, if you go through the MRI review, which is free, and a lot of people use it, and it's fine, it's going to be 5 weeks from now. If you fly here, you can be fixed next week. I'm just being honest with you. Look at all the scar tissue and herniation. It is beautiful. We're getting it all done. We're getting it out of here. This is the worst level. This is C4-5. If you look at the MRI, it's literally crushing his spinal cord and nerves. All right, you see a giant tear, and you guys see the tear, that black tear right there? That is the annular tear we talk about. And that's what we're here to clean up. Once I remove all this junk out of here, that back of the disc will seal itself off. You don't need disc seal, you don't need barricade, you don't need any of that garbage that doesn't work. It's all unnatural stuff. This is natural surgery. We're helping his body heal itself. We're not adding anything that God didn't put in here. We're just cleaning out the mess that is created as a result of the herniation through the annular tear. This is natural surgery. This is the best way to do it. We're just giving his body a little help, you know? Kind of like the United States is helping Ukraine against Russia. We're not actually fighting the war, but Ukraine's not going to win without our help. Maybe I'm saying something I shouldn't, but that's my opinion. And the help of other allied nations. The point is, we all get by with little help from our friends. Consider the laser to be your friend if you have a herniated disc. Consider Deuk Spine Institute to be your friend. Right, Henry?
Of course.
All right, so I got to make this herniation smaller because it's just not coming out. Now it is. See, you got to beat it up a little bit, and then it comes out. The reason is it's too heavy and dense otherwise, and that's why we use the laser to break it up. This surgery cannot be done without the laser. Have you seen me stick a single metal instrument in here like a grabber? No. The only metal I'm putting here is the tube and the endoscope. Here comes another herniation. See how it's floating up and out, right? We use hydrostatic pressure to do that. So natural, water pressure. Like a little river, artificial river we create. All right, more questions. I love questions.
Next question comes from Stacy on YouTube,
Stacy, hi.
asking once.
Oh, wait, before we go any further, look at that, guys and gals. That's the PLL, posterior longitudinal ligament. You see it?
Yes, we do.
Not what I'm zapping. What I'm zapping is the herniation, but just deep to the herniation is the PLL. You see that white thing down there? It looks like you could see the fibers, right? They're running pretty much left to right. That's north to south, we call it, rostral to caudal, head to toe. That is your posterior longitudinal ligament. And we love it when the herniations don't go through that because it makes it a safer, easier surgery for me and the patient. All right, sorry. Yeah, 5 minutes.
Next question from Stacy on YouTube asking, once the bone spur and herniation is cleaned out, what prevents future herniation? PRP?
No. No, when you clean out the bone spur and herniation, your body will seal the back of this disc itself. It just can't seal it while this stuff is here. So we go and remove this stuff and then your body seals it. Your body will make collagen to seal it. Just like you seal your skin when you have a cut on your skin. Now if you get a thorn stuck in your skin, your body's not going to seal around the thorn. You got to pull the thorn out first. That's what we're doing right here. This is like an internal thorn. This herniation is an internal thorn. That's a bone spur, by the way, right there. I'm zapping away. You know, I'm having a lot of fun here, Berndes. It may be a little more than 5 minutes, maybe 8 minutes.
Just tiny little whistle.
No, it's fine. I'm almost done. I mean, I could see the end. Look at that space down there. It's wonderful. We're almost done. That's the right foramen, and I was off on the left foramen. Oh, look at that herniation right there. All right, more questions.
Next question comes from Kelly on YouTube.
Hi, Kelly. Welcome.
And they ask, is there a new spine institute being built in Orlando?
There was, but not anymore. It's too expensive. We're probably going to pull the plug on the project. The contractors and the subs, they all want too much money. It's too expensive to build right now. So we were going to build in Orlando, but not anymore. At least that's where I'm at right now. I'm still waiting for a few more bids to come in, but the prices are outrageous. These people are greedy pigs. They want too much money, and then I have to pass it on to my patients. We already charge enough for these surgeries. We don't want to have to charge more. So, long story short, it's not something that's in our cards right now. But if I somehow get a subs that are reasonable and fair with their pricing, then we'll move forward. But we did all the plans. I spent $1 million expecting to build something, and then now I have to throw it all away. So it kind of sucks, to be honest with you. But that's how business is in this country. You take risk. Sometimes doesn't pan out. But there's an old saying, don't throw good money after bad money.
That's very true. My dad always said that.
Yeah. So just because I spent $1 million on plans and engineers and all that crap and permits, and now the price is ridiculous, I'm not going to keep going just for the sake of going. It's stupid. And I'm not stupid, you know? So I hate to say it, but right now Orlando's on hold, and unless somebody wants to make a donation. But it's too expensive to build. I actually sold my home to build the building in Orlando, and now I can't afford it. So we're a small company. We're not a big company. We're doing great things. We're doing things that big companies should be doing. But the truth is we're a tiny little company with just a few doctors with great big ideas on how to cure pain. But we don't have a lot of money, and we're not going to go to the markets and ask for investors because they're going to want, returns. And we're never going to compromise quality for money at this company. Not while I'm alive, and not while my son is alive and my daughter's alive. We're always going to put patient results first. Yeah. So well, the moment you get in bed with venture capital or private equity, they want money. They don't care about your medical results, how good you are, how happy your patients are. They just want a return on investment. And to do that, they'll squeeze the system. They'll push you to do things you shouldn't be doing, you know? Do more surgery than you should be doing, or do more expensive procedures. That's what's happening, by the way. If you look at pain management, all the pain management clinics are being bought up by private equity. And I'm almost done, Dr. Berndes, I promise. And the companies are forcing the doctors to do more pain pumps. Pain pumps are the highest paying thing done in the pain clinics and the surgery centers owned by these private equity companies. They're pushing pain pumps, pain pumps. You know, when I was trained on pain pumps, we would do maybe like 1 out of 30 cases was pain pump. And the reimbursement is so high, these companies, they're doing every single case is pain pump, right? And so they're pushing pain pumps on everybody because the profit margins are high. You're getting $10,000 profit per surgery, okay? Well, $10,000 profit's a lot of money. I mean, if you do epidurals, you're making $100 profit, maybe, you know? But with pain pumps, you're making $10,000 profit. So all these pain doctors are pushing pain pumps rather than sending the patient to get fixed with a surgeon like me. They don't want me to fix these patients. They want you guys in pain so that you'll come back to them and get a pain pump. I think that's unethical. I don't think that's right. I think doctors are supposed to do what's best for the patient, not what's best for the private equity company, not what's best for their local venture capitalists. So long story short, I'm against it, and I believe to always do what's best for the patient, which is what we're doing right now, fixing them, not making them stay in pain. We're done.
Sitting on, please. Thank you.
Any more questions? Type them up. I'll answer them for you face to face. Our next surgery is a
It's lumbar DLR.
lumbar Deuk laser disc repair.
DPR.
How many levels?
I think it's
2
2.
level Deuk laser disc repair lumbar for lower back pain, and the DPR,
And pretty
and a piriformis release. So this patient has disc pain, facet pain, and piriformis muscle pain, and we're going to fix all 3 in one surgery. By the way, it's interesting. You think about, but let's just show everybody, Henry, this tube, okay? Because maybe they didn't get a good look at it. The whole surgery, folks, 3 discs. Look at this thing. This tube is, I mean, Dr. Davis could probably tell us because he's used to playing with tubes this small. But this tube is 4 millimeters wide. Took you a while. All right, you guys see that? Pretty cool, huh?
Yes, we do.
Let me take it out, and then you can see the actual incision. By the way, we lost maybe 1 cc, 20 drops of blood, not much. Okay?
The size of the tube is what you can do with it.
There it is. You guys see that? No bleeding. That's about 5 millimeters. 5 millimeters. So, bam. Deuk spine. Go. Save the world. Dr. Davis, will you hold that for me, please? I'm just kidding. I'm just kidding, dude. I'm kidding. I'll hold it. I'll hold it.
I do what I need to do.
I'm a little bit of a hamster. A little hamster. I stir the ham. All right. Type up your questions, Henry, and I'll come and answer them for you. I'm very happy we got this done safely. And good morning, I'm Dr. R. Deuk Majan, CEO and founder of the Deuk Spine Institute. I'm here with one of my patients who's traveled far to come to Deuk Spine Institute, all the way from Michigan. What brought you from Michigan to Florida?
I was scheduled for fusion to have just my 1 disc, C5-C6 fused. I'd had disc herniation before in my lower back, had it done. I didn't want to have to go through that again, so I did some research. Found you had a good record. Your history is impeccable, so I decided to come down here and have it done.
Well, you didn't have a fusion, though. You had something else done.
Yeah, I'm sorry. So instead of fusion, instead of going through and the complications and risk of fusion, lack of mobility, I wanted to have laser. I talked to somebody in Mexico that had laser surgery, and she said it worked great. So I thought I'd pursue that avenue, and that's when I kept Googling and searching and trying to find right place. Some places had bad references. You had impeccable record, so this is why I came here, and I'm glad I did.
Yeah, so you were recommended for fusion by another doctor, and let's talk about that for a moment. They were going to fuse one disc, right? Number 5-6?
Correct.
Now, if you go to your surgery video here, you could see that we made a tiny 1/4 inch, 4 mm incision, and we fixed 2 discs, not 1, but 2. And it turned out that the disc that you were not going to have fused was actually the worst one. It was the one that was causing the vast majority of your symptoms. And the reason I'm talking about this is it's a common problem. It comes down to being misdiagnosed. And misdiagnosis happens all the time, all over the world with spine problems. And that's what we're trying to fix, is not having patients get the wrong diagnosis, because the wrong diagnosis will lead to the wrong treatment. Because treatments are always based on diagnosis. So if your diagnosis is C5-6 disc, the treatment will be fusion of the C5-6, but that's wrong because you had 2 discs that were problematic. We fixed both. You could see in that video, we were taking out lots of little chunks of herniation out of your C6-7 disc. Definitely needed to be done. How do you feel today?
I feel great.
Yeah, do you still have the same neck pain you had when you came here?
No, my wife can already tell that my shoulders are relaxed. My neck, I feel great. Feel very comfortable.
And you had your surgery just 24 hours ago.
Yesterday morning.
Yep, and you can see you have a tiny 4 mm incision with a Band-Aid. No metal, no fusion, no narcotic painkillers after surgery. We didn't give you opioids, so that's another plus to the Deuk laser disc repair.
I agree.
Yeah, you don't need to be on powerful painkillers. You're back on your feet already, walking around, not in the hospital.
Yep, great. I'm glad I had a guardian angel looking after me.
You did have a guardian angel, and you're welcome. We enjoy helping people like you have successful spine surgeries. Is there anything else you want to tell your fans out there?
Basically, if you need the surgery, if you're having complications, neck, back, definitely come here. I don't care what it costs you for travel or whatever. You can't, it's worth, priceless.
I agree with you. It is priceless to get out of pain and have no complications from your surgery, and nothing bad that hurts you or harms you or changes your life in a negative way. So congratulations. And when do you guys head back to Michigan?
Saturday.
Saturday. So you're going to spend a few more days here?
Yes, sir.
What are you going to do for the next couple of days?
Well, we plan on hanging out in the sun, but
yeah,
it's not the case right now.
I think, yeah, well, you could do. Oh, yeah,
enough
it's a
sun
little overcast right now. But this would be a good day for you to go check out the Kennedy Space Center. It's about 10 minutes away. They have all the displays and history of NASA, and it's really worth visiting.
I'll do that.
Save the beach for tomorrow.
There you go.
Sunny day.
All right.
All right, congratulations. You're
Thanks,
welcome.
Thanks again.
I'm here with my patient who traveled from California, Northern California. He had a herniated disc at C5-6. It was a small disc bulge. He was told by the doctors in California that he should just live with the pain, give it time, and eventually he'll need a fusion. Is that right?
That is correct. I was told that within 5 years I would be needing surgery. So basically what they were saying, live with pain for 5 more years and then we'll do something about it. One of the things that I've seen a lot of the videos is testimonials, and I will always say, this doctor sounds too good to be true. And actually it is true. I appreciate you, doctor. I really think that is really nice procedure, and the staff here is really nice. They're always very friendly and kind to get you through the process, because when you get told so many times that that's your new life, it's kind of, you're always thinking, is really the way I want to live? If I'm going to live a lot of years, why wait with pain? You know, you need to do something different. And always, whenever you see videos, you're always a little sketchy and saying, maybe it's not true. Maybe this is not what it is really saying. But today, when I felt with no numbness and no pain on the neck and just going through the process, I really been blessed. I'll be flying to California today. I honestly can't say much. You know, it's a miracle. Whenever I heard the testimonials, they say you're a tool for God. It actually seems like that's the way it is. It's a miracle through you. God works through you, and it's awesome to feel better, you know?
I'm so happy for you and your lovely wife who's here with you. You can see you had a tiny little incision. You had the Deuk laser disc repair for your herniated disc. You can see we were in there with the laser, cleaning out that foramen on the right side where the nerve was being pinched. There were a lot of pieces of herniation in there. And the laser cleaned them all out, and your surgery went perfect, and here you are less than 24 hours later. Feeling good, huh?
Well,
With
yeah.
a smile on your face. That's what I like to see.
You know, it's a smile of happiness. It's a smile of joy, you know, that it is doable. And I think no one should be able to be living with pain. I was so happy to see testimonials when they used to say, well, the one regret I have is not going in earlier and living 18, 20 years with pain. For me, it's been 3 years since July of 2020. It's been miserable because I've been with pain. And I've been told by doctors, let's just take time. I did all kinds of physical therapy, acupuncture, you name it, everything that's out there, and nothing seemed to help. And today, with 1 day of getting something really that's gonna be for life, it's amazing. It's a smile of joy, you know? If you are going through this trouble, don't hesitate on sending your MRI. When I did it, I sent my MRI for free review, and my answer was, yes, you are a candidate. Here I am today, flying back with literally no pain on my neck and no numbness on my hand, which I miss that. That's awesome.
It's wonderful. Now, what is your native tongue? What is your native language?
It's Spanish.
Are you from Mexico originally?
Guadalajara, Jalisco, Mexico.
Guadalajara.
Yes.
One of my favorite songs. Can you tell them in your native tongue how you feel?
Yeah. Quisiera decirles que si están teniendo problemas con una hernia en su cuerpo, manden su MRI, es gratis y les van a dar un resultado, una verificación si ustedes son candidatos. No vivan con dolor, porque el dolor les va a causar toda la vida y los doctores allá afuera les dicen que no hay solución, pero las soluciones existen, simplemente las tienes que buscar y creer, tener fe que tú vas a estar mejor. Si Dios te mandó a este mundo es para que vivas bien, no para que vivas con dolor. Así que te recomiendo que por favor tomes esto en serio, hagas ese paso de mandar tu MRI gratis y habla ya sea con quien tengas que hablar para que ellos te empiecen a guiar y te digan qué es el siguiente paso que tienes que tomar. Así que una recomendación con Dr. Deuk. Muchas gracias.
Muchas gracias, amigo. And Feliz Navidad.
Feliz Navidad. Gracias.
Safe travels, my friend. Thank you so much for sharing.
Wow, what a great testimonial from one of our patients who underwent the Deuk laser disc repair. I want to talk to you all for a moment about Deuk Joint Institute. We're getting ready to launch our website. We treat joints like the knees, and we're using a new technology that I developed here at Deuk Spine called the Deuk Plasma Rhizotomy. And what we're doing is we're targeting the pain nerves to the joint, and we're basically destroying these pain nerves where they travel on their way to the joint. And what that does, it's called a rhizotomy. What it does is it eliminates pain from the joint. I would highly recommend anybody with knee pain, arthritis of the knee, and if you've been recommended for joint replacement, don't get it done yet. Come try the Deuk Plasma Rhizotomy for your knee first. Ask for Dr. Patel or Dr. Davis. I don't do these procedures, they do. And the success rate is around 85% pain elimination. If your pain's gone, it's gone permanent, and you don't need a knee replacement. You just keep your knee. Knee replacements are invasive. You get metal put in there. It's a huge incision, very painful. It takes a year to fully recover. With our procedure, you're recovered in 1 day. You can go back to doing normal stuff the next day. You do have to get physical therapy to build your muscles back up. But aside from that, your joint pain should be gone. About 85% is our average. All right, let's take our first questions on this case.
First question comes from Micah on Facebook,
Hi, Micah.
asking, what are the chances this patient will need another surgery?
What are the chances this patient will need another surgery? Well, normally they're 0, but because we had tough time getting down to the bottom disc, C6-7, I would say the chances are 5%, 1 in 20 that they'll need another surgery. Normally it would be 0, now it's 5%, 1 in 20.
Next question from Rich on YouTube, asking Dr. Deuk, what procedure would you recommend for a ligamentum flavum hypertrophy diagnosis?
What procedure would I recommend for a diagnosis of ligamentum flavum hypertrophy? 0, no procedure at all. That's a diagnosis that's given to you so that you'll get a procedure like the mild procedure or a laminectomy. Ligamentum flavum hypertrophy does not cause symptoms. It is a finding on the MRI. We don't treat it here and we leave it alone. It doesn't cause any problems. My advice to you is do the Deuk laser disc repair to get your problem fixed. Have your MRI reviewed by me personally for free. It's from the convenience of your own home or your phone, and we do it virtually through the phone, so you don't have to come here. And you don't have to pay for it. It's free.
Next question from Betty on YouTube, asking, hi, the other week a lady had her muscle removed from a previous doctor. What can happen to the back? Thank you.
Yeah, great. You remember. Yeah, so we had a patient a few weeks ago who had thoracic pain, and she had a herniated disc, and the surgeon, not knowing what to do, took the muscle out, which is crazy. That's like you have a fire in your house and there's smoke and flames and somebody blows the smoke away. That doesn't put the fire out, that doesn't stop the problem. The smoke is secondary. Just like muscle spasms are secondary to a deeper problem. It's either the disc or the facets or both, or a fracture. She didn't have a fracture, she did not have facet pain, she had disc pain. And that pain was gone after the surgery. I think we did a testimonial on her as well.
Yes. Yes.
So we haven't finished it.
No, not yet.
So that testimonial is coming. So that patient we're talking about that we did her disc repair in her thoracic T3-4, I think it was. Her testimonial is coming. She did great. She's very thankful. Yeah.
Should be uploaded by tomorrow.
So what happens when you take muscle out? I mean, nothing good, right? You don't want to lose your muscle. But I think she could build up the muscles around the other side of the spine and hopefully provide more support. But it's a bad thing. Don't ever let surgeons do treatments that are not in your best interest.
And then, last but not least, question comes from Stacy once more on YouTube,
Hi, Stacy.
asking, does insurance cover the DLDR?
Does insurance cover the DLDR? Yes, no. I mean, does insurance cover everything you have done, every medication? No. We don't know if your insurance will cover it until we know more about your insurance, until we actually bill your insurance, then we'll know. Insurances will tell doctors, yeah, we'll cover it, and then they don't pay. So, is that covering it? My brother's a neurosurgeon. He's having problems right now with Aetna. They promised to pay for typical spine surgery like fusions, and they didn't pay. So is that covered or not? So now they're having to look at getting a lawyer to sue. I mean, what does coverage mean, right? So you want to know if they're going to pay. We don't know if they're going to pay. Even when they say they're going to pay, they don't pay. If you look at the bottom of an authorization form from insurance, it says, just because you have this authorization doesn't mean we're going to pay. It's there on every single authorization form. Look it up. So we don't know if insurance will pay. But we've had every insurance pay for the laser surgery, but they don't pay consistently because we don't have a contract with them.
That is it for questions.
All right, thanks for joining us. We'll be back shortly. Our next patient is quite fascinating. He has back pain, and he's coming from Sarasota, Florida. Now, he's got back pain from several different things. He's got 2 discs that are causing back pain. He's got 6 facet joints that are causing back pain, 2 piriformis muscles, and 1 sacroiliac joint. So we're going to fix 2 piriformis muscles, sacroiliac joint, 6 facets, and 2 discs. What is that? 6, 7, 8, 9, 10, 11 causes for his back pain. This just goes to show you why So many people with back pain have surgery or procedures that doesn't work because the doctors aren't making the right diagnosis. Get your diagnosis at Deuk Spine Institute. We're the best in diagnosing. We are very accurate, and we can figure out where your pain's coming from. Have a nice day.